All right. So my name is Katie Papia, and I am moderating with Brandy today. So many guidelines, so little time. We have no disclosures, and we're going to start with Teresa.
Hello, I'm Teresa Priestley. I'm a social worker at the Stanford Children's CF Clinic, and I have no relationships to disclose. So I am going to be talking about the wide range of surveys that we are supposed to be doing every year with all of our families, and sort of the pros and cons of distributing all the surveys. And I just thought this little picture was great because everyone loves doing a survey, right? So at our center in Emeryville, we administer the PHQ-9 and the GAD-7 for mental health, the food insecurity screening, the end-of-year CFF reporting. We do the CF Rise transition readiness surveys. We do the pediatric symptom checklist and the BASC. That's a lot. So one of the ways we help condense it a little bit is the PHQ-9, GAD-7, and the food insecurity screener we do all together in one screening. So that helps sort of limit the number of screenings you're giving people at least. We do this, I feel like most of the time, I'm not surprised by the results of these surveys. But they can be helpful to catch people that maybe you just happen to miss, or maybe parents didn't want to say something in front of their child. So it can be kind of helpful for that. We do it annually. And Kathy Hernandez, who is our wonderful database specialist, is the one who does a review of who's coming in that week and lets us know who needs the screening. Either myself or the medical assistants give the survey, and I am the one who reviews the screening if there's a positive result with families. I do know that some people use the survey as a great way to just discuss mental health. I don't personally use it that way because I talk about it in other ways, but that can be a great segue into a conversation. We document that the surveys were given in a confidential note and whether there's a negative or positive screen. And if there was a positive screen, we just say what we did and the support that we gave. I definitely give more details on the child's positive result than I would a parent's positive result. So. The end of year survey, again, Kathy does a lot of work for us. So she is the one who determines who gets those. And again, either myself or the medical assistants give the survey, and we do not document. We just let Kathy know whether they were given or not. Transition readiness. This one, we had sort of stopped for a while, but we do use the CF Rise surveys for patients 10 and up. I think it's really helpful for a few things. It can be really helpful to kind of have a conversation about things that maybe you forget about talking about. And it can give you a sort of a good baseline. Sometimes we're surprised by kids' answers on tests or on the quizzes. We tell them when we give them that they're not getting graded on this. This isn't like a, they're going to pass or fail. This is just for us to get a sense of where they're at in their understanding so we can have a conversation. Our dietitian is the one who helps track on our spreadsheet who needs those. The way we do this to make this a little easier is that once per quarter, we pick a CF Rise survey, and everybody who is 10 and up gets that survey. And so that sort of simplifies it. We're not trying to track everybody and what one they got. And it makes it a little more standardized, simplifies it a little bit. The medical assistants are the ones who distribute it when family checks in. And whoever the team member is who specializes in that survey topic is the one who reviews that survey with the child. So when we have one on that's kind of based on spirometry, breathing treatments, our RT is the one who reviews that. I do the insurance and mental health, so on and so forth. So that also helps divide up the burden a little bit. So it's not one person on the team who is responsible for always going over these with people. And also, some of those are tricky. And you don't have to know the answers to all of the surveys then either. So that one we don't necessarily document in the chart. Sometimes we might put a note in there if somebody really struggled with something, that maybe that's something we need to work on. Otherwise, on the spreadsheet that we have that tracks what survey everybody was given, we will make a note if somebody's kind of got about less than 70% left or on the survey, so that we can make sure to review that a little bit more with the child and the family. I love this picture. I'm not sure which one I'm feeling today. Maybe a mix of a few of them. So the modulators and mental health survey. So we have had a number of kids at our center who have definitely noticed a difference. Parents have noticed a significant change in behaviors after starting the modulators. And so we started using the pediatric symptom checklist. So when we have a kid who's going to start a modulator, while we're working on getting that approved, I will give them the survey and say, hey, just you don't have to send me all of the results, but at least keep track of them. And if they want to, they can send me the results, but I have them do it about once a week, leading up to before they start taking the modulator. And then after they take the modulator, I have them do it again. It's I don't do it a strict number of times, but I try to have them do it about once a week. They can do it every other week and just see if they're noticing a difference in those behaviors. I find it to be really helpful because I think sometimes otherwise people only pay attention after they start the modulator, and maybe they're not paying attention to the fact that actually their kiddo was doing that a bit before. But I think it's a helpful way to sort of have a little bit more objective view of what's happening. And so we do that for the first few months at least after they start the modulator. And I'm the one that distributes it. I'm the one that reviews it with families. The doctor also will kind of talk about it with them sometimes before that when they're talking about initiating the modulator therapy. So today's yoga pose is downward spiral. And the caregiver medical coping, I know it's something that a lot of people have talked about this year at the conference and in previous years. I feel like the BASC we started doing the more recently, and I find it to be incredibly helpful. And I did a little bit of a test run with it before I started using it because I was conscious of survey burnout. And so I asked families if they would mind answering the questions on it and to give me feedback on how helpful they felt like the survey was in sort of capturing how they're doing and how they're feeling. And 100% of them said it was helpful. So I have been giving this one out. I try to give it out annually. I also, if there's something new going on, a big change, the guidelines say that, annually, and then at changes in functioning or first hospitalization or things like that, more stressful periods of time, you can give it then as well. I usually give it annually. And I do not scan in the results into the chart. I do not talk about the results in the clinic with the parent unless the parent and child have been separated already in the visit because we're trying to do a transition visit or whatever. So I do not talk. I like this survey because I feel like it gives a really good idea of both positive things that people are getting out of caring for their child. So do you get a sense of satisfaction? Do you feel a sense of purpose? Do you feel more connected because of the care that you give this person? And then it also goes through things like, I'm stressed because I feel like I don't have enough time to do all the things that I need to do in the day. I feel anxious about this person when I'm not with them. So it goes over a kind of a wide range of things that people can experience. And if I notice concerning results on there that they're feeling really stressed about certain things, then I will call the parent later and go over that with them and just sort of talk about how they're doing. So it is not something I feel like is appropriate to talk about in front of the person that they're caring for. And I feel like this provides a really nice way for parents to be able to give us an indication of how they're doing. When maybe they're, a family that doesn't reach out on their own, or, they don't want to understandably talk about the stress they're feeling about caring for their child in front of them. So, which I appreciate. So, are the surveys helpful? So, for me, I have to say the BASC and the transition readiness have been probably the most helpful. And like I said, the BASC, because it gives us a way to check in with parents without them having to say things in front of their child. For me personally, the food insecurity, and the mental health surveys I find to be the least helpful. I can think of 2 times in 8 years that I've been surprised by the answer on those quizzes or on those surveys. So that one for me is not very helpful, but I know other people use it sort of in a different way than I do. And so they find it helpful for starting conversations and things like that. But yeah, I think there's sort of I know I'm talking about how you should do all the surveys, but I do think there is sort of, it depends on your center, and the feasibility of doing all those, and how much is it better to do a verbal sort of added into your psychosocial assessment that you do, or into your quarterly check-ins that you do when you see families versus giving them a piece of paper. And that's something you have to decide. If families have a lot of wait time between providers, maybe they want to do surveys. So challenges in completing the surveys. Staff willingness and availability, that I think may be one of the biggest challenges. Room shortages, depending on how many rooms you have in your clinic and how much you have people waiting, that can definitely be a challenge. Survey burnout, for sure. You can definitely get people going, oh, yes, I'll fill out this survey. And also, I think another big challenge is when you're adding something into your clinic routine, it is really challenging to remember to do it, because you just have your flow. And then also on the CF Rise one in particular, as well as the end of year survey, I have had a number of people who've been confused by the questions. And so that can also sometimes it means maybe you need to do it a little bit more verbally with families. So again, just getting all of the surveys done is really dependent on a number of factors in your center. And again, maybe a conversation might be more appropriate for some of the surveys than actually handing somebody a survey. So that is it. Thank you.
Thank you. That was great. And we're going to save questions for the end. You can put them in the app or ask at the end, and we'll have more of like a panel discussion. So make it a little more lively. And
hi, my name is Amy Plachta. I'm a social worker at the Cystic Fibrosis Center at Northwell Hospital in New York, Lenox Hill. Thank you to my team for being here. I see you. I told you not to come. We'll talk about this later. Thank you, Brandy and Katie. I met two new friends today as well, Teresa and Ashley. Thank you so much for having me here today and to talk about mental health guidelines. I have no relationships to disclose. Today I'm going to totally just focus on, Teresa, I can't believe how many surveys you're doing. I was like, blah. I'm going to really talk about the PHQ-9 and GAD-7. So to begin with that, I'm going to talk about why are we doing it, just as a refresher to us, because I know a lot of us are doing it, but maybe just a little refresher on why and what tools are we using to do that screening. So basically, we're doing the screening because of an amazing study called TIDES. And basically what that study showed was the International Depression Epidemiological Study surveyed over 6,000 CF patients and over 4,000 caregivers across 9 countries. And the key finding was that there was a 2 to 3 times higher prevalence of anxiety and depression in the CF population. And it's important to have depression and anxiety screening together. So this led to the PHQ-9 and GAD-7 being implemented in our centers. And the Mental Health Committee provided us a step care model for the interventions based on the screening results. So I wanted to show you, everyone knows this form, which I'm sure we have many copies in our clinic. So this is the tool that we're using, and this is the scoring that we do after we use the tool. So what are the barriers to implementing the PHQ-9 and the GAD-7? One is survey fatigue. We have a very famous patient at our center that took all the surveys, went to our doctor's office and said, no more, I'm not doing it. So that was a very clear message that we're over-surveying our patients. I'm sure a lot of us have also showed there's just a decreased number of visits per year. We don't know how many times we're going to see our patients in a year, and especially if they're going to be in person. And we know there's a lot of providers that are so excited and want to get into that room with them. So it's also making sure that we get a good pre-clinic huddle going, saying what order we have to see our patients in, so we're not attacking our patients when they come in. And another one that I actually have, always is a work in progress is the follow-up with mental health recommendations. So we can screen, we can show that there's a trigger for anxiety or depression. We can make recommendations for outpatient mental health or psychiatry. I call the providers, make sure there's no wait list, make sure they're in network, waiting for the patients to go, and it's what I want them to do and what the screening tool wants them to do, but the next step is getting that patient ready to make that next step. And also there was a study looking at survey fatigue called PROM, which is the over-surveying a patient's burden in CF. And what the study showed was that many participants reported survey fatigue, like our patient that went to Dr. Walker's office and threw the surveys on the desk, feeling overwhelmed by repetitive or lengthy forms. Frequent data collection led to reduced engagement or lower completion rates. Patients preferred shorter, more targeted surveys or verbal check-ins, and extensive questionnaires can reduce response quality and add emotional stress. So knowing this, what did our center do? Oh, one more thing. I'm also the registry coordinator. So when I understand, I love clicking the box, done, was the patient screened? Because I look at everything. So I love the registry, but the registry also shows that there is in the 2024 patient registry highlights, 26% of our patients have depression, 28% anxiety. There's also a decreased average number of encounters recorded per individuals. And there's also a spread of insurances throughout our patient population. So our toolbox has to be filled with a lot of resources that we can refer our patients to. And especially, during COVID, it was very, very hard finding a psychiatrist. It was, and even most people, still. So I thought that was a very interesting statistic. So knowing all of this, how did I implement screening, mental health screening in our clinic? How to present the screening tools, how the patients should complete the screening tools, reviewing the screening tools, provided the interventions, and follow up on the interventions. Should I hand a piece of paper to our patients? How do I explain why the screening was going to be done? Should they fill it out before, during, after the visit? will I be able to like run after the patient if I didn't see them at the end of the visit to go over their screening tool before they leave? How long will it take me to connect the patient with the provider, if their insurance or if there's a long wait list? And what's the time frame should I give them to follow up on a recommendation? It takes me a long while to realize it's more of me wanting them to go to a therapist than them. So what we do at our clinic is we do a great day, an ideal day, we do have a pre-clinic huddle where we do say what patients are coming in and what order to see the patients. When the patient comes in, I am the first person. I do get to go first. I'm so happy. I always say welcome to the clinic, and they are given a clipboard with some surveys on it. But I do say today we're going to be doing our annual mental health screening. Please let me know if you would like to do the screening today. It's more, I don't want it to be what my goal is. I do want it to be what the patient's goal is. I explain why we want to do the mental health screening. I do mention also, I'm talking really for 12-year-olds and up, that, with all the modulators and the transition to modulators, it is very important to me to know if there is changes on their screenings. And I also like to say, what has brought you any joy or happiness? Because sometimes I'm only talking about depression and anxiety. I feel like I'm always like the sad emotions. So I do like to ask them, like, give me the past 2 weeks, what's brought you joy or happiness? And then I review the questions and answers with permission to share with the team. So for example, if a patient reports that they are having trouble sleeping, we review why they're having trouble sleeping, and I do report back to the clinic team what those answers are with permission from the person that is doing the screen. Based upon the answers, I do create goals for the visit, which Brandy taught us some really great skills on how to collaborate with our patients and do shared goals. And then I give the handout and pass it off to the next provider. So I have always done this questionnaire verbally. I try to do it paper-wise. I try to follow up and chase after the patient. It never worked for me. I've always just sat with the patient and done the PHQ-9 and GAD-7. It takes me a little longer. My team knows. They know not to interrupt me. My name is on the door. It will come off when I'm done. But it is good because, for example, also when I talk about the question on the PHQ-9 about if you're eating too much or eating too little, I also throw in a few food insecurity question. Are you ever worried about when your next meal is going to be? So I can ask them that question like that. Do you have questions on how you're going to get your food next month? And then during anxiety, I ask, are there any reasons that you're not taking any medications due to copay, lack of insurance? So I try to ask other questions embedded in the PHQ-9 and GAD-7 that could help me prioritize their goals. And for example, if they said, I don't know what happened to my copay for my CF modulator, I can call GPS, I can figure it out and get them that answer at that visit. So hopefully that GAD-7 score will be lower by the end of the visit. I do want to measure success, even though I am the registry coordinator and love checking that box. I want to measure success beyond screening done. I want to make sure that the screenings do have some purpose and give some feedback that the patient needs and values. So by doing this, it reduces the paperwork burden. I'm not having anyone giving me a lot of papers in one of the day. It increases engagement between me and our patient population. It clarifies misunderstanding. A lot of people, even though the questionnaire is for the past 2 weeks, a lot of people are like, well, last month, and that I do like to try to focus on the past 2 weeks. But if something happened last month, I kind of want to know that too. And also, you get to ask more detailed questions if they did score high. I do want to give us definitely a case example of why the screening tool is really important. I had a teenager that came in and I could not understand what those tiers were about. And we slowly went through the PHQ-9, and I want to say it took us about an hour. And it was the best PHQ-9 I have ever done. She needed to talk. She knew what questions were going to come next because we've done the screening so many times before. And I think she just was waiting for me to ask that final question, and we got her the help that she needed. So I do find value in the PHQ-9. I do find the value that to give it if you can verbally, written on a piece of paper, because it's easy to miss some details if you're chasing after the patient at the end of the clinic. So thank you very much.
Thank you. Hey everybody, I am Brandy Middour-Oxler from Atlanta, Georgia, and I'm a pediatric nurse practitioner by trade. I'm also our transition program coordinator, and my best friend also has a son with cystic fibrosis. Her husband was diagnosed recently as well, and a few other family members along the way, which I feel like I always bring that with me into all of the work that I do. So today I'm going to talk to you about something called ADAPT-CF, a communication guide that I've developed along with many people in this room that I'm thankful for. And so the title of this is just, Can We Talk? This is not a paper screening tool. Here are my disclosures. I am a PEP trainer as well, so I see a lot of faces when we go around the country talking about great communication. Part of this work and some of the people in this room, the wonderful people are here, are part of this larger group, the Improving Life with CF, which is a primary palliative care partnership. Primary meaning that we don't refer people out to palliative care for any distressing symptom. We bring those resources into the CF Center and provide that from the wonderful staff that we have. If you do not know about this website, it is free, it is easy, it is CF specific. There is no paywall. You can download it. There's webinars, talks. This is not even what my talk's about, but I'm passionate about free things. The first time I went to NACFC and found a paywall when I went to download something, I've never been so bummed. So anyhow, our objective today is really to discuss the development of a CF-specific pediatric interview guide to support providers, all of you out there in the clinic, with effective palliative care discussions. And that can just be anything that's negatively impacting people with CF's life, and learn where you can access that guide. I do want to say the manuscript for the work that I'm talking about is under review right now, and I'm going to try to lean out of the science a lot and into the heart and humanity of it, because that's what I enjoy. And I think you don't want to talk about Delphi surveys. So to give you some background, I live in Atlanta. I live an hour away from where our clinic is, and I love that hour drive because it lets me really process my day. So one day at work, I read the consensus guidelines on palliative care, the evidence-informed consensus guidelines, especially the portion, it was recommendation 10, that if you work in pediatrics really talks about how we should approach this from a pediatric perspective. And I read that for children with CF under the age of 12, the CF Foundation recommends using the IPOS to guide conversations with children and caregivers annually and at disease milestones to identify these unmet palliative care needs that may exist. And I have to say, I read this and I thought, I do not know how we are supposed to do that. How am I supposed to use this IPOS as a guide? The IPOS is really for people over the age of 12. It's a valid tool, it's a great tool, but it's not CF specific. So how do I take this adult thing and talk with kids about it? And I literally thought about it all the way home to my home in Woodstock, Georgia, and parked the car and went, you know what, that's not my issue. Someone else can worry about that. Until a meeting about 2 weeks later where Anna Georgiopoulos said, Brandy, I have something I want you to solve. And she put it right back on me. And I thought, okay, I'm going to do my best and see what I can put together. So just to review, that IPOS has these like 3 buckets of areas. Physical symptoms, again, not CF specific, not child specific. Emotional symptoms, which includes patient anxiety, family anxiety, depression, and this idea of feeling at peace. Mark that because I had worries about that. How do we talk to kids about being at peace? And then also these communication and practical issues like sharing feelings, information needs, and just the practical support that people need to be successful in taking care of themselves with CF. And then also spiritual concerns. And we were not talking about those things in our clinic. So again, that goal was to look at all of those IPOS concerns and put them into a communication guide that was age appropriate, that really looked at that through a CF lens of what people commonly with CF were dealing with, and include those manifestations, and then to somehow make it open-ended so that this is a conversation that we're having in clinic that really helps to empower children to start talking about what's bothering them. So lofty goals, right? So when I thought about this, I thought about a child cognitive approach. I separated kids out into the way they think, their attention span, even how long they can talk in clinic, and came up with these 3 age groups, the 0 to 3 age group. And really those questions were directed to the parent. And the other 2 age groups were 4 to 6 and 7 to 11. And those questions were specifically designed to be asked to the children and then opened up to the parent for more information, just to really create that first voice for them, a place where they can talk about things. So this was a long process. So I drafted questions first, brought them back to Dr. Rachel Linneman, one of our fantastic pulmonologists and our center director, and worked through those questions several times. And then we put them to our mental health coordinator, who was Shayna Blair at the time, and she had input, and our social worker as well. And then after we were happy with the questions through this iterative process, we thought we should really check in with our diverse family advisory council and find out what they think about this. And I have to say, my heart was beating so fast when I talked to them. I'm like, are they going to want us to talk about palliative care issues with their kids? And Dr. Lindemann said they may not. And I was floored when they were like, yes, talk to our kids about what's bothering them. These are the burning questions we have, and we don't know how to always talk about these things. So talk to them with us. And also I ran it by my best friend, Shelly, who I got the Shelley stamp of approval, which felt great as well. So then we went to our wonderful experts as part of the Improving Life with CF group and got feedback from them. And that includes CF experts, palliative care experts, and stakeholders with CF. And then the boring Delphi process. Interesting, read about it in the paper. But we took this back to our PEP trainers, who are multidisciplinary experts in CF and relationship center communication. And we actually looked at what they thought, how closely this fit the IPOS. And if there were some questions that didn't fit the IPOS, but were really important in CF life, we kept them. So then at that point, we had what we call ADAPT CF, which is assessing for distressing symptoms and palliative care needs with targeted conversations about cystic fibrosis. And then we piloted at our care center and made it available to our group and later the public. So it was surprising to me that when we piloted with 19 patients and their families that we knew really, really well, that we found new symptoms and needs in 57.9% of them. And it was a real shock. One of my worries was, how long is it going to take to have these conversations? And the average conversation took about 13.6 minutes. The lowest was 5 minutes, the highest was 25, but again, the average of about 13. As far as those things that we identified, about 42% were emotional symptoms. We're not surprised. We know how high emotional symptoms are in our patients over the age of 12. They don't magically start at 12. They're younger than that. But I was surprised that in our really healthy kids, even 26% of them had physical symptoms that we didn't know about. And then 5% had the need for more information, spiritual concerns, and the need for practical support as well. What I will say is that while we were piloting this, we were had so many parents that were championing really adding this into our clinic flow and wanting us to continue the ADAPT CF in the future. So I talked about the idea of being at peace. That was something that worried me. Can children really understand this? Can we talk more about coping mechanisms to help them feel at peace more often? And this was the picture that helped me understand that children, I just don't give them enough credit. So this was a young girl that when I asked her, do you know what it means to feel at peace? Can you draw a picture of that? This is what she drew. So this would be crayon on paper in the room, to be honest, if this was an art piece that was going to be framed. But these are the people that she told me that when she doesn't feel at peace, she says it's not like happiness, but it's happiness kind of like it. And you often don't feel it when you're with your favorite people, it's afterwards. So she said this is when she's feeling at peace, these are all the people she's thinking about or has been around recently. Of note, there's someone on here she hasn't seen for years, but that's an important person to her. And she says it radiates out from your body, and those are the rays coming out. And she said she can feel that all in her body when she's going to sleep or even when she's thinking about those people. And I asked her, I said, do you need to draw legs on these people? And maybe you didn't have time. She said, Brandy, no, that's not where being at peace is. It's here. Okay. So it made a really great conversation about ways to lean into activities that help her feel at peace. So the ADAPT CF guide now is available on our website. This is an example of the 0 to 3 age group. It does link back to the IPOS domain, and then it starts with open-ended questions and probes as well. So there are 4 questions for the 0 to 3-year-old age group, 7 for the 4 to 6, and then for the 7 to 11, I believe there's 9 questions right now. And then where are we with ADAPT CF? I live in the modern world where all of you are living and having less visits. So the first year or so that we did this, we put it out to every single person and did it annually. And now we're having less clinic visits too and trying to figure out how this is really going to work. And it's especially hard with really healthy school-aged children that we're maybe want to be seen a couple times a year. But I think one of the great things about this is this does not have to be social work doing this. This is anyone with a heart that knows how to ask an open-ended question. So we're trying to figure that out in our clinic as well. And I want to give special thanks to all of the collaborators that helped with every step of this way in making it available for everyone out there. I do want to say also there's a care center in England. We've done a UK English version. They don't use throat swabs. They have all different language for the things that we do in CF clinic. And they are lucky enough there to use it in their in-home visits. Can you imagine how great it would be to go to someone's house and have an hour or 2 to talk with them? But that's available on the website if there's any UK people here as well. And that's it.
Thank you, Brandy. So I'm really excited to have our patient partner come up, Ashley, and finish us off before our discussion.
Hello, my name's Ashley Shaver. I'm 45 years old. I was diagnosed when I was 3. I still go to the same clinic where I was diagnosed in Tyler. There's my crew right here. Thank y'all. It was 1984 and my parents were sitting in the room and I was sitting up on the cold bed and Dr. Green comes in and he tells my dad, just hold on just a minute. I'm about to do something a little unconventional. And he kisses my forehead and he says, yeah, we're testing this kid for cystic fibrosis today. So that's where we kind of started. And since then, I've tried to be in every modulator study that I'm eligible for. So I started with Orkambi and then did Symdeco, Trikafta, and I'm still in the study for a left track. I can't really say that. It's study drug to me, so I hadn't got used to actually, the actual word. But before modulators, I just remember always fighting for like the next breath. That's how it kind of felt. Now I'm pushing, my next clinic visit back because I just don't have time. I've just got too much going on. And it's something that it's really weird for me, because up until 2 or 3 years ago, I was going every 3 months. I'd be on an antibiotic every 3 months or so, every, once a month, just depending on what was going on, what the weather was like. But I don't remember the last time I had an antibiotic. I have no clue. I got my port removed. I had a port for a while, for almost 10 years. And I think for the last 3 or 4, I didn't use it. And I was like, okay, Dr. Couch, it's time. Let's schedule it today. So there's been a lot of change for CF patients since the modulators came out. And I think the positive change is something that affects our mental health in a weird way. I'm not used to being this well, and it's strange. It really is. It's crazy. My dad uses the word like miracle, because I'm taking 2 pills a day now, and if I wanted to just take off running, I just take off running. It doesn't make a lot of sense that I'm 45 and I'm getting better than I was when I was 15, walking around a high school hall carrying an IV pole. So it is strange. And so when I go into clinic, my clinic's so easy to get a hold of. One email and I'm getting the information I need within an hour or so, depending on what the question is. But it seems like they always do have a plan for when I come in. The surveys, I think especially at my clinic, I used to have fun with the surveys because it was just too much. You could only ask an adult if he's, like a smiley face today. So many times before, I'm going to write some funny stuff. They knew that if I was having an issue that I would bring it up. I'm a little different than some, but what I find now, especially over the last year or so, is instead of handing me that stack of 10 papers where I have to fill out the 1s and the 2s and all that, it's more of a conversation, and that's, you spend, and it's not much time. I feel like I'm their practice subject. They get to come in and bounce new questions off of me and stuff. So, but, my dietitian will come in and she'll fill me in on, some new snacks out there and bring me a big old bag, or our physical therapist will teach me a new stretch or something because I'm old. And I think the verbal conversations, the actual conversations, are going to be a lot more help, because in my case, if I'm having an issue, I'm probably not going to tell you on paper. I'm a grown man. It's just, unless you see it in my face, you can converse with me and there'll be something. There'll be something that catches you, and maybe, you pry a little bit, do the questions that y'all are taught. And I think that's, especially as we get older, as a CF population, that's going to be where we need the most help and how we'll get it. Because my main goals when I go into clinic now is refills and resources. Recently, I went to clinic and I was looking for a program to help me and my wife do yoga. She's gotten me into yoga. And so they got me a hold of Breathe Strong, and boom, I got an email this past week saying that I was approved for a grant enough to do it for the next 6 months. So, and that's huge for me because, I mean, I'm at a point now where I no longer have to eat 4,000 calories a day just to stay afloat. But I mean, if I'm at 2,000 calories, I'm getting a little chubby. So I've got to do something now. You know, it's a change of focus for us because, like I said, I spent so much time trying to get to tomorrow, and now my 14-year-old, she's a freshman in high school. Now I'm worried about, how am I going to pay for her college? That's not something that entered my brain even when she was born. It was just something, let's just get to tomorrow. But she started a new school and really jumped into it and started doing cross country. That's about 2 miles. I'm not going to be running cross country with her, but I do jog with her, and that's just crazy to me because 15 years ago, that was not happening at all. We're every weekend, just about most evenings, we're out playing softball. She's a big softball player. So, and again, 12, 15 years ago, if I played softball for an hour, I'm down for the next 2 days, just drained. Now it's okay, it's getting dark, let's go in. It's just kind of regular. When the pandemic hit, I can remember a very specific moment. It was when the NBA shut down. It was drastic for me. It flipped my wig completely. My clinic, my doctor, Dr. Couch at the time, she immediately knew she knew my situation, where I worked, what I worked in, the whole thing. And she immediately sent my company a letter basically stating doctor's orders, he goes home. And so I spent the first probably 2 months at the house working. I had they transitioned me into work from home. And the clinic was checking in on me weekly. They knew that it was something that, it was all new to us, but they knew, hey, let's just shoot him an email. Let's just shoot him a text, just something, say, hey, what's going on? And it turned out, eventually that the 1 month turned into 5 months. And I don't think I went back for almost 2 years. But they made sure to check on me. And, during a deep part of that, I got, they pushed me to talk to somebody. And it turned out that me and the guy needed to talk to each other. So it was great. I mean, it was, we pretty much had some of the similar, situations going on. So it was just like, okay, man, this is cool. But I just want to say, thank you for all that y'all have done and continue to do, because I've been in every modulator study, and my goal is to be in the study for the cure. And I mean, if anybody's working on it, I'll be your lab rat. But I just want to say thank y'all very much.
Thank you so much, Ashley. Wonderful job. And we'll take questions either at the mic or you can enter them in through the app.
The mic would be great.
Oh, here we go.
Hold up. All righty. Oh, you guys have lots of questions. My goodness. How do you deal with patients and families who seem to be in a rush to get out of CF visits? If it's their annual visit and they need to do all the checklists, adapt CF, et cetera. So I'm gonna have you answer. No, well, for the checklist for both of you. Yeah, yeah.
So I always tell families, you have the choice of whether or not to complete each and every one of these surveys. You do not have to. We won't be upset at you. Like that is totally voluntary. And I explain what it's for. So if they don't feel like they have time, then they go. I will also say the annual visit, they do like 3 surveys, and the rest of the year it's usually 1. So it's not like, too horrible. But they always know that they have the choice not to do it. And I do have some people, and if they say, I do not ever want to do this survey again, I send a note to Kathy and say, please take them off the list of people to do this survey. Yeah.
Anything you want to add?
I'll ask a follow-up question. Does anyone use virtual means of doing any of these surveys, either on RedCap or emailing to the patients?
We do red cap.
You do RedCap? Yeah, because I've definitely done mental health screening where I've emailed it to the patient, asked them to finish it if they couldn't get to it in clinic. So that is something to discuss as well.
One person wants to know, Teresa, are you using the 17 or the 35 item version of the
BAS?
Yeah.
The 17.
Okay. How do you use CF Rise? Are you using the online portal? It sounded like you may have printed
We
it.
print out the quizzes and hand them out. No. I do think it would be lovely if people wanted to do them at home, but maybe I'm just overly cynical, but I have a sneaking suspicion that we would have a very low percentage of them that would be done before people came to clinic.
Do you adapt the CF Rise at all from, because I know it's been around for a decent amount of time, like pre-modulator at this point?
They've
and
been
if there's
updated.
It's updated?
Yeah.
Okay.
There is one question that our dietitian removes when she does it because she feels like for people who are on modulators versus not, it's kind of an insensitive question. And so she blanks that question out so that it's not even on there.
This says, how do you, oh wait, already did that one. Oh, someone on here is saying, Amy, I think we need to add your joy question to the mental health screening.
Yes.
It would be nice to have a highlight on there.
Yes.
Hi, Ashley. Thanks for the great talk. Since you don't like to fill out the mental health surveys, and we love your honesty with that. That's why you're here. What recommendations do you have to make it easier for patients like you to feel comfortable to discuss these mental and emotional health concerns with us all? Thank you.
I think conversation. A lot of things can be conveyed through facial expressions and just how somebody says something, and then you can kind of move on from there. You can tell if somebody is actually having an issue if there's an issue there. Sometimes, that's how I feel. If I would be an open book.
Ashley, I did have a question. Do you usually come to clinic by yourself, or do you come with a partner or a caregiver?
I've come to clinic by myself since I was 16.
Okay.
Like sorry, but
Yeah, you're
that was one of my things is like when I was able to drive, the one place that my parents really let me drive was to clinic. So it was like, no, I'm going by myself.
How would you encourage us to engage your loved one or caregiver or someone in your life if maybe they needed extra support? Because I feel like that's something that I've struggled with, and maybe some other providers do as well.
I would think, especially with my wife, like if somebody called her, just direct, because like she doesn't usually have a lot to do with my clinic visits anymore. There's no need to. I don't need somebody at 3 a.m. to help me with my IV. So, she doesn't have to put that. She doesn't have to be involved in that stress. So, if there was ever a question, like we should check in with the spouse or whatever, then I would just suggest a phone call. Again, I don't know if the email would reach.
Yeah.
You know, you just never know.
Yeah, go for it.
No.
Sadly, no, but I think try now.
Hello. Okay.
got
Hi. I'm a social worker from the CF Center in Southern Nevada. This is my first conference, so thank you all. I'm loving it. Anyway, how do you pitch to your team getting in there first? Because sometimes I can. Later in the
Great
day,
question.
like I kind of start, if the nurse hasn't gone in yet, I'll start with someone later and work my way backwards, but then it ends up being a rush. And just this person needs the height and weight, this person needs the PFT. And I'm very well respected on my team, but just what's a good conversation starter I could have for that?
My team is here too, and I'm looking at them like, I mean, I've been in the CF world for 28 years. I've had the privilege, and I can say they hired me too. So, I do, and one of my patients says it, like, it helps the patient as well if the social worker goes in first, because they know what's going to happen for the rest of the clinic, the team. We get to be able to express the goals of our patients to the team who might be like, oh my God, they didn't do their glucose tolerance test. They need a bone density. Like, no, they really want to talk about their sleep today. Like, so I think we are able to set not only the patient up to succeed, but also the clinic team up to succeed. So I definitely, maybe we can make that a mental health guideline, to put social workers or your mental health coordinator in first. I don't know if my doctors over there want to say anything. Like our clinic coordinator Nadine is here too. Like, we work really well together. It's pass the baton. Like, yeah.
Well, and I'll be honest, I would rather see my social worker first, because in my situation as an adult, what I am mostly needing is, hey, can you help me with this exercise program, or just that's where my focus is on most visits.
So you can take that back to the team that the adult with CF just told you to do it. Yeah. There was a question on here. You have another. Go ahead. Yeah.
Thank you. I'm Lenny Sicilian. I'm from Boston, and I'm an adult provider. I think, as Ashley pointed out very well, this is a whole new world in CF. Do you find any difference in uptake on any of these tools with people who are recent diagnoses, or people who have been, as Ashley was, indoctrinated into this is the way you take care of CF for your entire life? We see a lot of new patients in the adult clinic, and they're not just young people. They're in all spectrums. These processes are very helpful, but I'm interested in knowing whether we can target them a little better.
I think that's a great question. I feel like the teenage years are the worst to be diagnosed. It's like you want to be the same as everyone else. And we have new diagnosis in the teenage years all the time at Atlanta and the adult population. I almost think that when I've seen our adults get diagnosed, they say, finally, I have an answer. I'm not crazy. So for our teenagers, it's a tough sell, honestly. And I think for us, really talking with them openly about what we need to get accomplished, and also hearing their priorities and really negotiating how that's going to work, and making sure that their priorities are important to us would be where I would lean. I'd love to hear.
I also think to slowly introduce all what needs to be done. And I really tell our new patients, please expect to be here 2.5 hours at minimum. Like, I think that sets people up to understand that this is not your regular PCP office visit. Like, you're going to know us, and we're going to know you. Like, and you're going to know every inch of corner of your new office here. Like, it's definitely just trying to give them the tools to know what they expect before it comes at them.
Yeah. Anything to add, Teresa?
No.
Okay. Checking to make sure no one's standing there. So there's a question on here. If doing screening informally, what is the ethical obligation of how to inform them that you are assessing and will be documenting? I would say I should have said for ADAPT CF, we have something we go through with the parents just to let them know what ADAPT CF is. And that's really well communicated, and they can opt out of that and say no if they would like. So that's my approach with that. How about?
Yeah, I mean, I do say we're doing a screening using a PHQ-9 and GAD-7, but I would like to do it verbally, not on. I mean, I have like a piece of paper there and I'm scoring, but I'm not. I do say what the tool is and if they choose to use it or not.
I ask people, I do tell people whether or not I'm putting it in the chart, or at least I try to remember to. But also, if I ever have anybody disclosing anything that is sensitive, I ask them if they would like it. I do try to ask how they'd like that documented, or if they want it disclosed to their parents, or, just the standards on consent.
Here's a question on if the PHQ-9 or GAD-7 is elevated, do you increase the frequency to more often than annually for that patient?
I don't remember the last time I had a positive screen.
Really? Okay.
I think if I did it, I feel like I get the answers through verbal conversation.
Okay.
I don't, everybody puts like they've never had a sad day in their life. Like, I'm like, okay, whatever. I know.
If you put 2, then it's over.
Exactly. I'm like, I get it. When I go to the doctors and they give it to me, I'm like, I've never been unhappy a day in my life. I'm great.
Great.
I don't want to talk to anybody. So I think that we are supposed to do it every 6 months then, but I just don't get positive screens, and I don't know if it's because we have a conversation and so they feel like it's superfluous or what, but yeah.
You'd be screened next clinic visit if you do get a positive screen.
Right.
Well, I feel like we go over,
Right.
we're start talking about your mental
Yeah,
health.
and calling and following up as well. But one thing I did want to plug was the CFCBT training is now virtual. So if anyone's interested, I give you the QR code. It's a great resource to be able to use either abbreviated in clinic or if you're able to do therapy with your patients. So, and it's all providers, doesn't have to be mental health oriented. So. Oh, we have someone. You can ask your question.
You do it. It's all you.
Hi, I'm Kendria. I'm at Nashville and Vanderbilt Adult Clinics. I'm a social worker. So I have an interesting take on some of this when it comes to screening because I'm also the quality improvement lead on my team. So I'm trying to work on balance because if you want to talk about fatigue, I have fatigue. I have the fatigue because I'm in 2 labs. So I'm ready. I have my annual screenings, PHQ-9, GAD-7, but there's the health related needs screening that we're working on right now in the lab. And then there's also the second part of the anxiety, depression. And so you're testing tools. I mean, because we want to get the information. And I do know, and I don't know exactly where in the social work code of ethics it is, but I know in our role, we're supposed to push forward and champion like research. So I feel good about that part of it. But I think the balance that I'm struggling with is, I think the conversations you were saying, I get so much from that from patients because I am the last person to see a patient. So I've had this conversation with my team, so I'm not going to go back there. But I will say, it is fascinating to see them, like 4 people see them, then I see them, and then I come back into the workroom and say, did you know?
Yes.
Do you know, I say that all the time. Oh, no, I didn't. Divorce, CPS is involved, whatever these things. And I'm like, because of the questions I'm asking. So I do see the benefit of being one of the first people. But again, I'm just trying to find that balance because I do see the benefit of these questions. I ask a blanket question of, as far as, your mood, is there anything that has been affecting you to the point where your sleep or your eating has been affected? And that is a blanket question because I get all kinds. My dog was hit by a car and has passed away last week. It kind of people just tell me all kinds of things. No one else on the team is asking that question. So I have my screenings that help me with that. And then I just blatantly say, is there anything I'm missing here? Anything that's affected you to that level where you're not sleeping well, eating well, whatever. But again, the fatigue, I think, can be on both sides because as much as I feel like I haven't had many, I think I know them well enough. There's about 360 patients that I see, and that I see annually. And And so again, there's also the guidelines, like we're supposed to see them. I am trying to add as many screeners in on this annual visit as possible. And again, being the last person and then being there for like an hour already probably. So it's just a balance. I'm not exactly sure what I'm saying right now. I'm basically saying, does anyone else feel like they have a balance? Because
Yes, definitely.
we want to keep moving forward in our careers, and and we want that information to bring back to the foundation and all. But again, there has to be some way of like either the conversations and the screeners and everything, and just finding a way that people don't get tired of it or burnt out and quit.
Right. We were talking about this before, how we get graded, right? If we do the mental health screening or if we see the patient once a year, and if that number is not good, you feel that's a reflection on you, right? So it doesn't matter if they declined or if they have a cognitive impairment. There's no option to say declined or couldn't complete, right? So we do look at it as a grade of S on the team. So it's a really delicate, hard balance.
Your question about so many people brings up, there's a question on here about how many people you are seeing in your CF clinic. So I think it might be helpful just to mention, if you don't mind.
We only have 60 at our location. The Palo Alto location has 3 or 4 times more than we do. And they also have a much more challenging room situation. And so they find it very difficult, even just from a time perspective, to be able to give anybody any other surveys. And they've talked about being able to send it home and try to have people do it that way. But yes, it does help. I also feel like a huge key in us being able to do this is I cannot manage all of those surveys by myself. Like no one person on the team can manage all of that by themselves. I mean, congratulations to you who manages all of them. But I think the key to being able to get it done is having a team that is willing to work together, to have multiple people collaborating to get it done. Because otherwise I think it just creates too much burnout for any one person to manage all of it. And I think the spreadsheet that we have that goes through, it has all of the tests that they need to do, like lab work and all of that stuff, and when they got that done. And then it also includes like CF Rise and the other things on it. So it's sort of an easy way for anybody to go in and look and see what people have gotten. But the size definitely makes a difference. Room situation makes a difference. Survey fatigue of your particular patients. I mean, there's so many factors, and that's why I was saying I think you have to kind of look at for yourself what works in your clinic, and some things are going to work better than others. And I think how you use the tools makes a huge difference. And also, I mean, I will make a huge plug for the BASC, because I feel like that in a pediatric center is really helpful. And I don't feel comfortable asking a parent those questions with their child in the room. And it is not, one of the things we forget sometimes is separating them out, starting when they're 13. So, there's just so many factors that go into it. So it's how we manage to do it, but it's not easy.
What about you, patient-wise, numbers?
So I'm a combined pediatric adult center. So we have around 180-ish patients. So, and I'm the only social worker, and I'm also the registry coordinator. So love both.
Teresa, I wanted to ask you about the BASC, if you've ever used it as a self-screening tool or you always ask the questions, and then like what resources do you tend to give following that screening?
Usually it's just been more of a conversation check-in of like, one, normalizing, like the most frequent one is like, I feel like I don't have enough time to do the things that I need to do during the day. Or I worry about my child when I'm not with them. And so some of it is just normalizing the challenges that people are experiencing. I mean, I always ask about if they want mental health resources, but I feel like most of the time it's normalizing and them just having an opportunity to talk to somebody about it.
Thank you.
I wanted to give the numbers too, because there's only one reason we have someone that does transition. It's because we have a huge population. We have about 750 between our pediatric and adult location, about 450 in adult. The rest are in pediatric, and I follow about 300 of our teenagers. So we have multiple. We have a mental health coordinator that is here. We have several social workers on the adult and pediatric side, and then me on top of that. So it's a lot of bodies. A lot of bodies, yeah.
Ask your question.
Yeah.
Thanks.
It works.
Yeah.
Good.
Anyway, I'm Catherine, and I'm from the University of Wisconsin, and I'm just starting to help develop a role for a pediatric clinical pharmacist there on the ped side. And I'm learning a ton, and I wonder a lot. And so one of the things I'm wondering is, can the electronic medical record be a tool to help download or upload these surveys to the patient's MyChart, if that's possible in your electronic medical record? And can, let's say, a request for the patient's or the caregiver's top 2 or 3 items for the next visit, and maybe it's sent out. I have to toot the horn of the quality improvement group at the UW, which did not include me. So that's why I'm learning a lot and wondering a lot. They did a trial of sending MyChart messages to patients and families a week before or so the visit to help identify their top, let's say, 2 or 3 items they wanted to discuss. That allowed us during our huddle to then streamline our time based on the patient load that particular day. And then we have multiple providers. And we only have one mental health coordinator, one social worker. So that person couldn't always be in the first person, right? Because they could have 3 8 o'clocks or 4 8 o'clocks. So it helped us a lot. I watched. It helped. That was just a really good project, I thought, that they did. And I was wondering what you guys think of that, if it's possible, don't know if it's possible. And then as far as workflow goes, I also wonder too, this is just a question. Maybe it's like totally wrong and you can't do this, but why not ask? What about having co-visits with different disciplines that often ask the same questions? It came to my head when you said, I was talking, the patients want to have, the refills and things like that. Or I have questions about my insurance change or blah, 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 blah. Not that that's what I think a clinical pharmacist does, but I will tell you, it's a place that those concerns can land versus having one person say one thing, go in and talk about it again, and now you've extended these, visits. So I'm wondering if we could even do like a role model, like a modeling visit within your team based on what disciplines you have, and do virtual patients within your own team and say, what questions do you ask? And that's great if you ask them, but let's find out so that we can streamline them. Those are just thoughts.
Yeah.
Those are my wonders today.
I do have to say, myself and my dietitian, we do these co-visits a lot of times, especially if they're like, I got to rush out, we can't do it. We'll do like a piggyback session together, because a lot of our questions, if either they're really underweight or overweight, have a lot of mental health concerns, we'll do that together. The one thing with the mental health screening, because of the suicidality question, I like using REDCap because it alerts us when they complete it and we can see it. So I don't really know those alerts in MyChart per se. So that's why I like using REDCap. And I usually call them and let them know, I'm sending you the mental health screening if you can complete it. So I know, and they know that they're receiving it. So if anyone else. No.
Okay. Hi, I'm Julie Lehrman from University of Michigan in the pediatric side, social work. And we actually, if you have Epic, we do a pre-clinic. So I think a week beforehand, they get the PHQ-2, GAD-7, and a distress thermometer that we use. And we started that prior to COVID. And so our families are used to it. Some never fill it out, and that's fine. And others do. And then it's kind of really normalized different things and organize them for the visit. And then we do the PHQ-9 annually, but we like to take it in the clinic room because of question number 9. But I do know with Epic, they have best practice alerts. So we get, the other social worker, psychologist, and myself get alerts if they're at a 4 or above. so that we can make sure we don't miss anything accidentally. And then also just another plug, we do a lot of CF Rise with 16 and up at our clinic. And our nurse coordinator, who's amazing, actually got an CF Rise embedded into our Epic.
Oh, wow.
That helps with tracking so much, because I used to have to try to figure out a spreadsheet and it was a nightmare. And then we've also been able to delegate it to different disciplines. And so we've had more team buy-in from that. So I will say the pre-clinic questions, I feel like has been received well, because it's cutting to the chase and they know what to expect and all of that. So if you need any of that, I'm over here because we have a charge package for the CF Rise. If I'm happy to give information out.
That's wonderful. Thank you so much.
That leads into this question really well. What are your tips for engaging the whole team and not placing the full responsibility on screening on the social workers and the mental health coordinators? Yeah.
I can say, like, if I'm on vacation, I know I'm looking at my nurse practitioner who's amazing. Like, I know she can do a screen perfectly well. So you just know your team really well, and just have resources available if you are away.
Mm-hmm. I don't know. Have a good team. But I do think it helps when you put it in sort of a strengths-based way that also looks at how it might actually support, like doing this thing will help you, right? Like not me as the social worker, but will help that provider, right? Like I think, hey, if we start doing this, maybe our kids will have a little bit better gauge and we're not feeling rushed when they turn 21 and we have to kick them out to adult that we forgot to cram a bunch of things in, right? Or whatever. I think if you have a team that's feeling a little bit more reluctant, maybe finding ways that doing these surveys is actually going to be beneficial. Don't lie about it. Find things that are actually going to be helpful to the team.
I know for me, I partner with my dietitian again, who I just say, like, it's just like a mutual thing of like, this needs to get done. And then it's whoever gets to it. So it's kind of like, who's your backup, right? Like, who can you align with that understands the goal of this? Yeah. So.
This question is, how do you deal with some of your families that have the most mental health needs, but are the ones that are declining screening? Do you have a way that you approach that or that might work?
Conversation. Mm-hmm. I feel like I get the most out of conversation with people. And I do have a pretty comprehensive annual thing that I go through in my head. And if anything's come up or I walk in and somebody's face looks different today or, then I don't know. I just use conversation and document it.
Mm-hmm. I think for me too, sometimes it's tabling what you wanted to talk about and just tabling what they're about that day and really building that relationship. Yeah. And sometimes doing a lot more listening than asking questions. Yeah.
I definitely, when I walk in, I do try to say like, hey, how's it going? Like, is there anything that's concerning you today? Anything you want to bring up? And so, yeah.
Yeah. All right. I think that was it on here. So, yeah.
Ashley, you have any closing comments for us? You've been the highlight.
You are the highlight for sure.
No.
Okay. It's been a wonderful session. Thank you,
everybody.
everybody.